provide some level setting, and then we'll transition into hand it over to Joel Cantor, my colleague, who's the director of the center, and he'll moderate our conversation. We'd also ask you to please complete. We'll be sending a link for an online feedback survey after this webinar, and we would encourage you, if you would please, it should take 2 minutes to complete, and it helps us do our work a little bit better. So if you would, we'd appreciate that. Oliver, next slide, please. Acknowledgements. We certainly want to thank the support, the Robert Wood Johnson Foundation, for their support for this event. Should note that the views expressed here for this forum do not necessarily reflect those of the foundation. And it always takes a village, and it certainly takes a village, as we're all working remotely and finding our way over the last 7 or 8 months. So certainly acknowledge our colleagues, Oliver Lontock, with whom many of you have interacted and received emails, and he's organized this event, and certainly thank him. Our other colleagues, Bram Poquet, Manisha Agarwal, and John Palatucci. And again, thank you to our panelists in advance for sharing their expertise and insights, making yourselves available for really strong and enthusiastic prep calls, and for participating in this discussion. Our goal is for everybody to leave here feeling like it was time well spent on a Friday afternoon. Just a little bit about the Center for State Health Policy. Some of you, in looking at the registrant list, many of you are familiar names to the center, but clearly some people who are joining us for the first time. The center was launched in 1999 with core support from the Robert Wood Johnson Foundation. We're a translational health policy center with a mission to inform and support state health policy in New Jersey and around the nation. Really, our focus is on policymaking in New Jersey. You'll see the center's research and project portfolio, the areas and the domains that we focus on: health system performance improvement, population health, access to care, long-term care, health and long-term workforce, and long-term services and supports. I would also say, and it's really, I think, relevant for today's conversation, is one of our other primary roles is to be a neutral convener, to bring different perspectives together to talk about important policy issues. And I think really that is the role we're playing today. Oliver, if you would, please. So a goal of this policy forums, this series of policy forums we're hosting, this is the second in the series. We hosted one back in July, looking at the impact of the pandemic on small employer health insurance. So the goal is really to address some of the most critical health and healthcare policy issues that have been impacted by the COVID-19 pandemic. And I think we all feel that every aspect of our personal and professional life has in some way been impacted by the pandemic. Through this forum, we like to draw on timely and relevant data and include expert discussion on policy strategies, both to address long and short-term challenges. I think we've all been disabused of any notion that life is going to be normal in the next few months. This is a long-term challenge we're going to be dealing with, on top of long-term and challenges that have existed long before the pandemic in March of 2020. As I say, we held a session, our first forum was in July on small employer health insurance. Topics under for consideration for future forums. We're planning one for January of 2021, looking at the continuity of care for complex patients, the transition from accountable care organizations to regional health hubs. The next one that is under development is looking at some of the barriers to workforce and program licensure. And I think we're going to probably talk about that a little bit in the context of substance use disorder treatments and some of the challenges with licensure programs. And I think Erin and Bob can speak to that, and Suzanne as well. And then really in the spring, we like to start digging into some of the social determinants impact and addressing health-related social needs, such as food and housing insecurity. And certainly both of those areas have had substantial impact as a result of COVID-19. Oliver, if you would. So just showing a couple of data slides, just again, providing overall context. Here's the suspected drug-related deaths in New Jersey, looking back 2019, comparing 2019 to August 2020. And this data come from NJ Cares, the state data set, data site. What's important here, and again, I would ask the panelists to opine on this a little bit. You see that spike in May that compared to 2020, there was a spike in suspected drug-related deaths. And I think there was some thought that that trend could continue over the summer. And it's a little hard to kind of tease out what the takeaway here is. But it doesn't appear as if we've seen that consistent spike and that jump that we saw in May carry out through the end of the summer. We can talk a little bit about in the panel discussion whether or not as we go into the fall and look through this last quarter of the year, whether things may have changed economically for people, whether there might be other things that might influence whether or not that number, we're going to see more of a trend upward in the remaining months of this year compared to last year. Oliver, if you would, please. This is an interesting slide. It's looking at treatment admissions, and I don't think there's anything that's really surprising here, particularly as you start to look at March of 2019 at the start of the pandemic and seeing inpatient admissions drop pretty dramatically. And we saw that across all sectors, not just for substance use treatment or behavioral health treatment. People were avoiding the hospitals. People were told to avoid the hospitals. And I think it's, these data are reflective of those trends writ large. And one of the conversations that we'll have in the panel discussion is, well, then how did people seek treatment? What was the proxy to that if people weren't getting those inpatient services? Oliver, if you would, please. The final couple of slides that we just want to present are really looking at, because this is a policy webinar, so highlights to regarding some of the amendments to treatment services, rules, and policies. So this slide is really just a summary timeline. Again, reiterating that these slides will be made available and we'll circulate them. So I'm certainly not going to read to you and take the time to go through all of this. But I think what is important here to see is, looking at when the federal response of March of 2020, I think what's important here is to take a glance and look at the breadth and the depth of some of these policy changes, both at the federal level, and then we're going to look at some of the state changes here. But we see that there is an acknowledgement and a prediction of the need for telehealth and remote treatment options that were going to be required at the beginning of the pandemic. And that certainly we saw that we were able to see that bear out over the summer as more people access treatment virtually. It also addressed trying to reduce barriers to medication assisted treatment and outpatient therapies so that people were able to access their medication and facilitate their being able to get the medication that they needed to treat their disorders. Oliver, if you would, the next slide, please. And here we want to obviously acknowledge our state colleagues, and Suzanne Boris from the Division of Mental Health and Addiction Services can certainly, I'm sure she'll have more to say, but really acknowledging the work of our colleagues at the state who have borne a tremendous responsibility over the last 8 or 9 months. And having both their professional life, I'm sure, consumed by doing this work. So acknowledging all of our state colleagues, one of whom is joining us today, and those who may be joining us as a participant. It's really, you can't overstate what a Herculean task was before them over the last 8 or 9 months. So here again, just a snapshot of New Jersey's policy response that was executed through the governor's executive orders, through regulatory changes at the agency level, just highlighting a few here from the Division of Mental Health and Addiction Services. And again, it really mirrors some of the, the policy thinking at the federal level of trying to increase access through virtual treatment, through telemedicine, trying to offer creative solutions like doorstep delivery options for opioid treatment providers to be able to pick up their medications. And again, I think this is illustrative and acknowledgement of the urgency of the situation. Oliver, if you would, the next slide, please. Again, here, it's just illustrative of the breadth and the depth. I would, on this slide, I think it's important to call out, and many of you, I'm sure, are very familiar with really the effort it's been consistent, but it was highlighted in the month of September, the coordinated effort between the Department of Human Services and the Department of Health to really push out and widely disseminate the naloxone kits. And it was really, I think, a public service campaign, making them widely available. At the end of the month, for 3 days, it was, I think, 35, 38 pharmacies around the state were, or maybe it was, I think, probably 135 pharmacies. Suzanne can correct me, but just this vast number of access points to be able to have the naloxone kits available, again, in recognition of the severity of the problem that we're dealing with. Oliver, if you would, please. And again, just an acknowledgement to, at the state level, of the amount of resources that are being directed to address these issues. A few highlights here, just this is from last year, so FY 2020, but money going toward county correctional facilities, thinking about treatment options at the local level. I really want to give a loud shout out to Reach NJ, the addiction treatment hotline, and we're going to talk a little bit about how that can be used to help people navigate through the process when trying to enter into recovery and seek help for themselves or a member of their family. Such an important resource, and where there are opportunities to advance that work. There's also $25 million through Human Services to support COVID-related expenses. And then DCA and the Office of the Attorney General and Community Affairs looking at some money for integrated electronic health records. And next slide, I think this might be the last slide. And looking at our colleagues at DOH and Mental Health and Addiction Services, been really, really successful in working with CDC. And this is pre-pandemic, but have really successfully, through the Department of Health, garnered a lot of funding from CDC for Overdose Data to Action Award, and doing evaluation of some of the programs that have been implemented to try and address the opioid epidemic. And then Suzanne certainly can talk more about the SOAR grant at the Department or Division of Mental Health and Addiction Services. That's the state opioid response grant from SAMHSA. And again, I think it's important to see here that in these pretty dire fiscal times, that in the FY 2021 budget that was just passed on October 1st, that Governor Murphy allocated $100 million across 8 state agencies to continue to fight the opioid epidemic. So I think that's a substantial point. Oliver? These are just some resources. Again, all the websites for the organizations that our panelists represent, and some other links to relevant reports, our reports, and some others that may be of interest to you, and we'll certainly post them. If you can continue. I think that's it. Next. Okay, so that is a very quick run through in terms of providing some level setting and some context for the conversation, which is really why you all came. You didn't come to listen to me run through the slides. So I'd like to take a moment to introduce first our director of the center, many of you have worked with Joel for years, but Joel Cantor is a distinguished professor and director of Rutgers Center for State Health Policy. He'll serve as the moderator for a discussion, and our really talented, enthusiastic, and committed panelists, and we're delighted to have them join us today. Suzanne Boris is the Assistant Division Director, the Office of Planning, Research, and Evaluation at the New Jersey Division of Mental Health and Addiction Services. That's part of the Department of Human Services. Robert Budsock is the President and CEO of Integrity House, a substance use and behavioral health treatment facility up in Newark. Steve Crystal is our colleague and close colleague and friend at the Institute for Health. He's the director of the Center for Health Services Research, a Board of Governors professor, and a School of Social Work. And this is an area of Steve's research focus as well, leading his team. Heather Ogden is an advocacy coordinator for National Council on Alcoholism and Drug Dependence in New Jersey, and she's certainly an advocate for the population and really understands some of the policy issues. So we're glad she's here to represent that perspective. And again, our colleague from Rutgers, Erin Zerbo. Dr. Zerbo is an assistant professor at the Department of Psychiatry at Rutgers, New Jersey Medical School up in Newark. And Dr. Zerbo is also director of the Northern New Jersey Medication Assisted Treatment Center of Excellence. So welcome to all of you. Thank you for joining us. And Joel, I'll hand this over to you.
Great, thank you. And special thanks to Margaret, who has been our leader within the center in organizing this series and organizing this event. And also special thanks to our panelists who are joining us today. I'll just echo what Margaret said, which is that really they were tremendously generous in helping us shape the questions we're about to ask and the focus of this panel generally. So we've set aside about 45 minutes for, I'll start out shooting some questions to the panelists. And I would encourage the panelists to sort of chime in, even if I don't call on you, if you have a response. And then we will save about 30 minutes at the end, 25 minutes perhaps, for Q&A from the audience. And you'll see, as Margaret noted, that there's a Q&A box on your screen. Because of the size of the crowd, we have about 105 folks so far. We'll strictly be using the typed in questions, and we will do our best to get to them. We'll have to do some triage, I imagine, because we won't have time to get to all of them. So really appreciate folks participating in that way. It's so much more fun in the room, but that's life. So let me begin with a couple of very broad questions that I'll put to really all of the panelists. So start at the 30,000 foot level. Really the first question naturally is, so how has the pandemic affected substance use disorder treatment and services? Let's try to touch on inpatient, outpatient. Let's not forget alcohol, medication assisted treatment, and so on. So that's really a question for all of you, and I'll let Zoom choose. So I'll go around the Hollywood squares here, and so when I start with Heather, and then we'll go to the others. Go ahead, Heather.
Thank you, Joel. Thank you, everybody. It's an honor to be here today with such esteemed panelists. Slightly intimidating, but you know, I often am asked to be on things because I am a person in long-term recovery from both substance use disorder and mental health issues. And I obviously wear that on my sleeve since that's how I'm introducing myself. How has it affected treatment? It has affected treatment differently through the course of the pandemic. So we had a lot of heart-stopping moments in the very beginning because there was a lot of uncertainty with both treatment facilities and doctors and hospitals and people that were seeking services. They didn't know where to go. Like all other fields, it seemed very chaotic for a while. I do have to give a shout out to our inpatient programs, especially for navigating through this as quickly as they did, because they had to worry about, COVID, isolating people for COVID, and did they have COVID within their facilities? So it impacted it greatly, but from my perspective, just on a frontline level, I had a lot of people calling. People were afraid to go to treatment. They were afraid to go to the hospital. That has, treatment seems to have alleviated a little bit. People are still very afraid to go into hospitals. And we are getting reports now at this point in the pandemic that there are a lot of people seeking assistance for alcohol-related issues, more so than in pre-COVID days. So most of the peer specialists and the network that I work with, they're saying they're seeing a lot more people seeking assistance for alcohol-related disorders. So that is not surprising to anybody on this panel or anybody in the field. We know that about 6 months after any kind of disaster, numbers tend to go up for people seeking assistance with both mental health and substance use, especially for alcohol and marijuana. But because we have such a huge opioid problem, especially in the state, we do expect to see more people. Bob will know a little bit more about the trends on when people are seeking treatment. I only know them anecdotally. I know that a lot of people will try and weather through the end of this year. And then in like January and February, we'll see a resurgence again of people that are looking for more assistance. That just seems to be kind of the pattern getting through the holidays. And so like everything else, it's ebbed and flowed. And I think a lot of people who work in the field have really done a great job of trying to keep up with the daily changes that were happening during COVID.
Thank you. That's a great overview of a lot of really tough issues. Why don't I turn to Bob next? And again, feel free to add about the impact of the pandemic generally on SUD treatment from your perspective.
Okay, thank you, Joel. Thank you, Margaret, for this opportunity. I want to start by providing a little bit of a snapshot. So the question is, how has the COVID pandemic impacted addiction treatment, mental health treatment in the state of New Jersey? If you go back to March 24th of 2020, our entire world was turned upside down. There was fear, there was uncertainty, and we were doing our best to continue operations at Integrity House. And we provide residential treatment, outpatient treatment. We have the full continuum of care. On March 24th, the 11 of our partners that we work with closely every day stopped admissions into their programs. Some of them stopped for a month or two. Some of them just took a 2-week hiatus just because everyone was, there was a lot of uncertainty and it was a little overwhelming. So when I look at that point in time, March 24th, and then I look at the slides that Margaret presented to us earlier, and you look at the slide number 7, and we see the increase in overdose deaths during the month of May. So in 2019, we have 248 overdose deaths during the month of May. But in 2020, we had 309 overdose in the month of May. And also when you look at the slide for admissions, and again, I started with March 24th. Let's look at the month of April for admissions. Last year, we had 4,455 admissions during the month of April. During the month of April of this year, we had 2,419. So 2,000 fewer people entered treatment in April. And we had approximately 50 additional overdose deaths in the month of May. So there's really a connection between the programs that stopped taking admissions and the fewer people in treatment and the more overdose deaths. The other thing that I wanted to say is, how has it impacted treatment and recovery that COVID and the associated shelter-in-place orders, the social distancing, the requirement to isolate in many cases, that completely disrupt the recovery community. So recovery happens in the community. And back in April, we were forced to close the community. So you go along with the fear, the uncertainty, the programs who stopped admitting clients, less admissions, more isolation, and we saw that spike in overdose deaths, which has leveled off since then. But during the height of the pandemic, it was really concerning. And it was unlike a spike, unlike anything that we have ever seen. The other thing I just want to add quickly is that the reports that I get from our admissions department is that there were many individuals that were scheduled to enter treatment in April, and they did not arrive because of fear, uncertainty, and in some cases, we just lost track of those folks. we're not really sure. Even if they were a criminal justice referral, the drug court coordinator says, listen, we can't find them, that they're on the run right now. And unfortunately, we received some reports from the drug court officers that some of those individuals overdosed and died. So that was our addiction treatment community was hit really hard at the height of the pandemic.
Yeah, thank you. Difficult things to hear, but so important as a starting point for this conversation. I want to get to the other panelists as well. And so, but I would ask you to also sort of fill in kind of what services were stood up, what services were sort of once the initial shock was over, it's not even over. Kind of how did providers try to compensate by adding additional outreach and services? So I'll go to Erin next on that. There you go.
Yeah, and that's perfect because Bob is speaking, Bob and Heather both kind of talking more about the inpatient side. And so our clinic in Newark was firmly on the outpatient side, so that OP level of service. So we switched to entirely virtual as of March 23rd. And thinking back now, because it was just remembering back on that time, we all have trauma from how bad it was at that time. It felt like the world was ending. But honestly, thinking back on it now, I have a little bit of guilt that we did not keep an open walk-in clinic, at least for part of the time, because it's just tremendous access issues, obviously. So we did everything by phone. And I think policy-wise, the important thing for this group to hear about and for everyone to really drive home and realize, the policy changes at the federal level are what enabled us to get through this pandemic, and we're still in the midst of it now. But federally, the regulations were very quickly relaxed so that telemedicine could basically be used in any scenario, that you could use any platform, you could do state to state, and that you could initiate, do an initial evaluation and prescribe all controlled substances. Initially, there was a problem with opioids, so that took several months to correct. And I'm talking about pain medications like oxycodone, et cetera. Buprenorphine as Schedule 3 as a controlled substance was allowed to be prescribed via just telemedicine with these relaxed federal regulations. So basically overnight, we turned into a telemedicine clinic doing everything over the phone. And that was really crucial and amazingly helpful and very life-saving for a lot of people. And what we've realized is that we're actually comfortable doing it by phone, because I think all of us, the biggest requirement for telemedicine had been also to have the visual component. And there was all these murky regulations around buprenorphine where they were supposed to come out with further guidance federally about exceptions, and they had not yet. So we were already waiting for further guidance. And so when the pandemic happened and kind of everything just got relaxed, it made it really clear that it's possible to do this by audio only, and that it's safe to induct people over the phone. And I personally now have done 45-minute evaluations over the phone, and I feel perfectly comfortable prescribing that person buprenorphine, even though I've never seen their face. And doing these phone interviews, you can hear the timbre of their voice, you can hear their thought process, you really do feel that you get to know them over the time of that phone call. And so I think what this has demonstrated is kind of launched us forward astronomically in terms of telemedicine. And I think we really need to maintain that and keep that, because there's so many people pre-pandemic that had trouble getting to the clinic because of work and childcare. And I see Heather nodding like crazy because these are the calls that she gets, right? And clinics make it really hard to work with you. A lot of clinics, if you miss a couple visits, now you're discharged or you have to wait a week or two, people ran out of medication, like has real implications to not be able to make it to the clinic. And so I think the kind of silver lining for this is let's continue to use telemedicine in this way and allow audio only access, which is really crucial for our more disadvantaged patients who don't have access to smartphones, don't have access to internet or broadband connection or whatnot. And so we need to have that audio only component. Just the last thing I'll say is most clinics now have walk-in hours and have returned partially on site. And the other thing that we've realized in kind of stage 2 of the pandemic is, oh my God, how much social disconnection is traumatic for everyone. That suicides, we know that they're up. We're already starting to see that data. And I think we're going to continue to hear all these horror stories about people being just isolated during the pandemic. And it's really been kind of surprising for me how much it means for a patient to come in and, we're masked, we're sitting socially distanced, but just being in the room, there's an in-person neurobiological social connection component that you can't get over the phone. And for our less stable patients, that in-person component has been crucial. So it's taught us really two lessons. One, let's use telemedicine much more broadly and allow audio only and be more relaxed with that. But two, of course, we need to have in-person available because there's something special about that some people are going to need kind of no matter the situation. And so looking back on it now, I don't think we should have closed down 100%. I think we should have kept always an in-person component and just tried to do it in a socially distanced way.
Thanks so much for that. I'm going to turn to Suzanne, and we saw on the slides just the incredibly rapid pace of policy change. It happened, government doesn't move this fast, but it did. Erin mentioned the federal response. The state also responded. But Suzanne, going back to these top level questions about the pandemic impact, and I'll add, and sort of who's left behind. I also feel free to comment on what it's been like drinking from the fire hose at the policy level.
Well, one of the things overall are treatment admissions, because I think the slide you gave was more focused on the heroin and other opioids, but across the entire system, our admissions were decreasing. We were getting, quite concerned about that. And then they started to increase again in May. Like in April was our lowest count, and now they are increasing. And right now through September, our admissions are at over 7,000, which is still lower than last September, but at least it's a good sign. So one of the things, from the division perspective, is we totally switched off our fee-for-service programming. Most of our addiction services are fee-for-service. And because of the pandemic, we were concerned about providers not being able to sustain themselves with clients obviously not wanting to come into treatment. So we did emergency payments, and all the agencies had to test to this, and they had to remain open. So none of our agencies were permitted to close during this time that at least we contract with. So we had emergency payments to get over this hump, and actually the fee-for-service was just turned back on October 1st. So we're back into our fee-for-service model. Not to say if something happens again, there's a second wave, we're geared to move into emergency mode and issue, contract, advance payments to agencies. We also did the same thing on the mental health side. So as far as that went, no clients were left in the dust, with not being able to, get their treatment funded. We're also very fortunate with the budget that was introduced this year that we sustained no cuts to services for Division of Mental Health and Addiction Services. And some of the reasons were because of Medicaid now covering a lot of stuff, covering a lot of the services. And we had, as a result of that, had underspending, of course, we didn't have to pay our money out because it was being covered by Medicaid. So one of the pluses of this whole thing, which is amazing through this whole budget issue, was we absolutely had no impact to services, in spite of the pandemic. And then another positive thing that's been happening is the federal government has been coming up with money. And as you saw on the slide, we just recently received now another round of SOAR funding, the state opioid response money, round 2. And this time we were given $66 million a year for 2 years. So this is allowing us to maintain all the programs we started under the last SOAR, the 2-year program. So that includes numerous work programs, STAR programs, a lot of recovery support programs, or prevention programs. And in addition, because of this additional funding, allowing us to stand up some new programs. I think our list, we have about 40 new things that we're going to be doing with this SOAR money, in addition to maintaining what we had, things that will enhance access to treatment, enhance access to medication, having, within the constraints of DEA, having mobile medication available, having open access, working with urgent care centers to, allow open access. So we have a lot of programs, just be on the lookout. You'll see them either being issued via RFPs, to allow this access, to clients, for services. So, so that's the, one positive thing, that it hasn't had an impact on the amount of programming we're able to do and the services we're able to offer. And it's just a matter of getting over the hump, getting clients comfortable with, not being afraid now to come back, to agencies, come back for services. And obviously that's changing because we see the admissions are going back up. And we know that our agencies are usually testing clients, checking temperatures, so, to be safe.
Thank you. So I'll just note, we've used about a third of our time for me to ask you all questions, and we've covered 2 of 15 questions. So I'm going to try to speed things up a bit. But before I do, Steve, anything to add briefly about these high-level questions? You're muted. There you go.
Okay. Can you hear me now?
Yes.
Yeah.
Okay, great. No echo.
No
Okay.
echo.
Got it. Yeah, I had a few points. If I could just take a couple minutes before you make the transition to the next question, because the sequence in which you did this was wonderful, and I think that I was thinking about whether in all of these discussions about what's happening in the state, have we reached saturation in terms of understanding what's happened? Well, no, we haven't, but we've reached quite a bit of convergence. So I think there's some things that, from looking at all the data and integrating all these conversations, that we actually can say about what the roadmap looks like. Those of you who are more expert than I am on what's happening on the front lines can comment and see if I got any of this wrong in terms of trying to make some broader statements. But I want to make a few points that I just wrote down listening to all these wonderful substantive presentations that might help us to envision what the next steps are. Number one, we have had a huge natural experiment, and we truly need, as with all really big natural experiments, to dig in and understand it, understand the details of it. What has been the variation in the implementation of the flexibilities, and ultimately, how safe and how effective has this transformation been? And stemming from that, what kind of evidence do we have on which features of the flexibilities, the transformation, if you like, one kind of transformation in outpatient treatment, in OBATs, another kind of transformation which is really important to talk about in the OTPs, with an even more powerful medication that has great potential for retention and also potential for overdose and misuse, methadone. The third point I want to make is that the context has changed in a very important way in New Jersey with the transition from close to 0%, less than 10% fentanyl in C samples back in, say, 2013, 2014 to, if you look at the most recent weekly figures, it's essentially all fentanyl. You can hardly get heroin without fentanyl. And in many cases, it's pure fentanyl. So this is a fundamental change in the market. We thought for a while that early in the epidemic that the shipments from China were being disrupted, and that there was temporarily less access to fentanyl, but as we would have expected, that didn't last very long. So that is a change in context. And when I think about the overall trends in overdoses in New Jersey, I think of the efforts that the state has made as kind of you're having to run faster and faster to stay in the same place, and the heroic efforts that have been made in the state to really push out more services to reduce barriers have really buffered the impact of that, which without these changes, it would have been even more catastrophic, because it's much more dangerous to be a street drug user now. So the fact that we have even kept it from being worse is a big transformation. But what that also means is it can't go anymore. It's already 100% or close to it. So I think we can now, people are understanding a little bit more what's out there, how they may be able to protect themselves. I think we have real opportunities maybe to push the overdose curve down a little bit with finding out what works. So I think it's really important that we're digging in and understanding we're finding that there's a lot of variation in how the flexibilities are being taken up, and it's really important to figure out which of these can or should be continued and what SAMHSA will allow. But this is a really a critical natural experiment. Fourth point, we always have to be looking carefully at retention, because retention is the potential Achilles heel, or looking at it the other way around with the glass half full. If we can increase retention, we can reduce the overdoses. And if we understand what the bright spots are, which providers and which strategies are retaining people for longer, we know that as long as we retain people on treatment, we can get their risk of overdose down to maybe a third. Fourth point, the current system does not fully, it's moving towards an integrated system, but it doesn't fully address structurally the incredible burden of comorbidity, mental health, substance abuse, and medical comorbidity. And we're evolving towards new structures that deal with that, but we're not there yet. I think we'll see much more in the coming years. So the rethinking together about what the shape of the system should be going forwards. You know, we have receptive state agencies. We have organizations like Camden Coalition that are really helping to push this rethinking. We have a lot of different Medicaid models from other states that we can look at. There's much more that we can do with data to inform our efforts almost in real time. We know who the high risk groups are. We need to create structures to intervene more assertively with methods that have been successful in mental health, for example, assertive community treatment type models. We're making gradual process in MOUD after medically treated overdose, but we have way more that we can do. So when you put all of this together, potential transformation in the OTPs, we're going to move towards a mixed model where we're using the telepsychiatry, the telemedicine where it's appropriate, but bringing people selectively in for the in-person, and responding to having personalized medicine and finding out which individuals are more responsive to in-person peer influences, provider influences, which ones will do fine. So we're going to evolve towards a mixed model, and if we're able to put all of the evaluation, continuous evaluation into the field as we do all this, I really think I'm less pessimistic in that I think that we have a good shot, if we do everything right, at making this a more manageable problem and reducing those overdose numbers in the next couple of years. So that's sort of what I think is the not saturation but convergence.
Thank you all for those initial comments, and it's nice to hear a little optimism in there. Let me, we've talked a little bit about telemedicine, and that was one of the sort of major shifts that we saw in all of this. So let's dig a little deeper into that. Let's talk a little bit about sort of what are the sort of the major modes and the best modes, and Aaron talked about voice only as one. Who benefits the most from telemedicine, and importantly, who's left behind? And then let's also touch on questions of quality of care and how telemedicine might affect the quality of the therapeutic relationships and the sort of the standard measures of quality that we use in the field. So I guess I'll put Aaron on the hot seat first, since you raised the telemedicine issue earlier. So why don't you go ahead?
Yeah. It's been interesting because I think it really depends on the person. Some people love the telemedicine and they don't feel the need to come in person and like audio only is enough. Some people really like the video, and then other people just don't feel connected in that way and they want the in-person component. So it kind of comes back to what Steve was saying and a lot of the other panelists, like it's about personalized medicine. And I think it's leaving options open for people. As providers, I find telemedicine tremendously helpful. I feel like it's easier to reach people and whatnot. But on the other hand, you're missing that in-person component, and some people really like that. So from what we've seen, there's just certain people that are really happy with it and others that aren't so happy. And so I think we need to have a flexible treatment system that is able to accommodate both types of people. And video, of course, is better than audio because you get that visual of the person, and especially if you can see their home environment, you can get a sense of how chaotic things are. That can be really helpful. But we haven't found that it's necessary to induct and start treatment for people.
Thanks a lot. Bob, can you chime in on this point also on the niche, if you will, for telemedicine?
Sure. So what we're seeing is that in our outpatient centers, approximately 80% of the individuals that are engaged in treatment are doing it through telehealth. And, that's overall it's 80%. What we see is that in the suburban locations, such as Toms River and Morris Plains, it's probably closer to 95%. And in the inner city locations, such as Newark, we have more individuals that want to come into the facility. And they want to come into the facility for two reasons. One is because they may not have the technology to effectively communicate through video conferencing. They may just have like a flip phone. They may not have a smartphone. So they're limited with the technology. The other assumption that we have and feedback that we've received is that a lot of the folks in the Newark area, they want to come to a safe recovery environment. So they prefer to come into the facility to receive services as opposed to using the telemedicine route.
Thank you. That's really informative.
One of the things I'd like to add is with the latest funding that the department got from the CARES Act, the $25 million, there's money available to purchase phones and phone service for consumers. So for those consumers that might not have phones, this shouldn't be a barrier because there is money available to do exactly that.
And Suzanne, that's an amazing response to the barrier that has existed. And we've known this from day one. I remember going back to April during the height of the epidemic, where there was a guy that was a graduate or a former client of Integrity House that was just kind of hanging around our facility because this is where he comes to get some connection. And I had a conversation with him about connecting through AA meetings or even outpatient services through the phone or telemedicine. And he did not have a phone. He didn't have a phone. He uses the phone of his neighbor that lives downstairs from him. So that's how disconnected he was. So it's great that that the state of New Jersey has recognized that this has been a barrier for many poor people, and that the resources are going to be available to get them connected, especially if we have the second wave coming or the third surge, whatever is happening right now in the world.
And Joe, the other thing I want to mention, I don't necessarily consider it as telemedicine, but I call it virtual recovery. So just as much as telemedicine is happening on the treatment end, I oversee many prevention and recovery support programs, peer-run programs, and we have had to adapt using what we call virtual recovery. So we do Zoom meetings and stuff. And what I hear from my providers are attendance at those meetings has doubled, because now we've eliminated barriers of transportation. So I know one of my large hospital chains, has double clients coming to these meetings. We do strengthening families, a prevention program. Our providers have adapted that to a virtual format, and you're able to interact with the families and play games and do activities. So I think another really important component, to this is the whole concept of virtual recovery.
I think the most important thing about all of the virtual tele supports that we're talking about, I think we all want to keep them, and we want to keep them as an option. This is not an either or thing. Like, we need both. Some people need in person, just what Erin was saying. Some people need to be in person. Some people are much more comfortable in the virtual formats. And with the lifting of the restrictions, it has opened up a whole new world to a lot of people that would never have come near treatment or near a support meeting or reaching out to anybody. There's a certain level of comfort. And I know that a lot of people working on the front lines are very worried about the restrictions being put back in place and losing that option, because, we really need to start individualizing this and making more things available to people. So we really want to keep them as an option, but not switch everything over. This is just adding
Just
to
to
our
add
arsenal.
to what Heather is saying, I think it's very important. There's been a wonderful sort of resurgence of support for harm reduction lately with the legislature, but by the same token, having to reach into the advocacy space. But from a national point of view, there's a lot of belief that SAMHSA, and depending on who the future leadership of SAMHSA is in part, but that at least under the present leadership, SAMHSA could be poised to take some of these flexibilities away. That they're not persuaded that by all of the kind of evidence that we've seen of what their role has been, and we cannot assume that they will be allowed to continue at the federal level. This is going to be a big advocacy effort, and and even if we get different leadership, it's going to be very important to have that advocacy out there, because we could find. I mean, I kind of see the rules that existed pre-COVID as pilot programs for methadone and pilot programs for buprenorphine that got frozen into place over the decades because nobody wanted to do the political lift of saying, we've learned how to do this and it doesn't need to be a pilot program anymore. And there's a lot of debate about whether you should be able to prescribe opioids without any special, all the opioids you want without any special training, but you can only prescribe MOUD, a Schedule III drug under, these limited circumstances. That's a legitimate debate, but the key point is that there's going to be a lot of sort of collective advocacy work to be done to make sure that those flexibilities are even available.
Thanks. I'm going to move us along a little bit and being very mindful of the time. I mean, we probably should have scheduled 3 or 4 hours for this, but very rich discussion. So a lot of our questions and discussion, and some of the questions are starting to come in through the Q&A in the chat, and have to do with populations that have traditionally had difficulty accessing services for one reason or another. People experiencing homelessness, people with major educational barriers, low education, people without access to technology, and it's great that the ability to purchase technology for them is there, but could I ask those working on the front line, sort of, how are we able to pivot to fill the gaps for these sort of hardest to serve populations? If so, how? Do I have a volunteer I could call?
I can start, because I've actually in Newark, I think another silver line, and I hate to say silver lining to the pandemic because I feel like we all say that now, but another good thing has been kind of addressing this homelessness issue, and I think it's brought it to the forefront. I almost look at it as like shock doctrine, like we're all on this video virtual conference right now. Our lives are totally different. We sit alone in our house and work. Like, it's just I think all the rules are done right now. So let's like kind of take a larger view and kind of see what's happening. And what we realized is that we can't, we really are our brother's keeper, right? We can't have people out on the street unsheltered. And I think the rush to put people who are experiencing homeless into hotels ultimately was a rush to not allow COVID to spread through the streets. And it was like trying to contain some kind of outbreak. So I think it was maybe not necessarily for the benefit of those people. I think, you know, people were thinking about the city and other residents and stuff. So it's like, kind of, let's round them up and put them in a hotel. But what has happened is we've seen the incredible benefits of non-congregate sheltering. So normally shelters are these large dormitory style, and it's very hard to get sleep there. People are stealing your stuff, et cetera, et cetera. And now we've moved people into hotels and use vacant hotel rooms. And you can see this a lot in New York City. There's been a lot of articles about this, a lot of political unrest on both sides about it. But we've seen this kind of amazing transformation of people who are able to be in these hotel rooms and saying it's so much more private, they feel so much more secure, they have their own space, and that this is really the right human thing to be doing. And somebody pointed this out in the homelessness advocacy world, and I was like, this is so incredibly true, that if you lack a home, it's really a lack of ontological security, like it's your actual beingness. Because if you have a home, it's a place where you can go, where you don't have to answer to anybody and you don't have to follow any rules. And people who live in shelters are under constant rules. I just had somebody the other day describe how there was a carbon monoxide malfunction in their shelter, and within an hour, the entire shelter got shut down and moved to somewhere else, and he was blind. Somebody else helped him pack his stuff. He found out after half his things had been stolen, including his medication. He no longer had a phone. Just so much chaos and stress, and people who are homeless live with that every single day, whether they're in a shelter or whether they're out in the street. And so I think it's realizing that we can't treat people this way. And so now that we've moved all these people into these hotel rooms, it's not right to move them back to congregate sheltering or just put them back out on the street, that we're stuck in a way. So let's have a long-term sustainable solution. And the city has really, the city of Newark has done a great job to kind of activate resources. And we're seeing all these stakeholders come together that should have been doing it pre-pandemic, but we just weren't having these types of meetings, where now we have housing organizations and mental health agencies, and everyone's at the same table. And we have the Newark Housing Authority moving people along with vouchers and trying to break down these barriers. And we all know this stuff is very complex, but we all need to have a seat at the table together and really push this through. And I think the pandemic is helping us just kind of, you know, let's get this done, because now it's urgent at a different level.
Yeah, I agree with Erin. I think that this pandemic has put a spotlight on everything that advocates have been yelling about for many, many years. Like policies that we needed changed because they were barriers to treatment or they were barriers to recovery. All of these access barriers that were suddenly gone within a stroke or two of a pen, and we need them to stay that way. And also, I find it really interesting, there's been a great combination of different stakeholders because of these formats. So this call is a perfect example of how things could potentially be fixed. We have people who oversee funding, we have people who oversee treatment, we have medical professionals, we have data experts, we have somebody from the front line. And, you know, a lot of times our decisions are made within our own little silos, and that's not working. Like, all of these elements have come together and COVID has spotlighted it. People can't concentrate on recovery and wellness if they don't know where they're going to sleep or where their next meal is coming from, or they're worried that somebody's going to steal all of their belongings. It's just not going to happen. We're not focusing on the social determinants that are an integral part of everything else. So, you know, I hope going forward that we have more of these conversations with these various stakeholders, because it takes everybody coming together to put all of these different pieces together, or we keep doing the same thing and getting the same results, and then we act surprised. So.
Right. Thank you. So some questions, comments are starting to come in through the Q&A, and I'll encourage that. It is that time. I'm going to try to sort of integrate some of those and sort of continue on script a little bit. I'll winging it here, admittedly. So one topic I wanted to introduce, we've talked a lot about telemedicine and related issues, is, you know, there's a lot of enthusiasm about certain, so I'll call them high touch approaches as well. And I'm specifically thinking about hospital-based peer recovery. And I know that a lot of work's been going on that. We're getting involved with that also with Steve and addiction psychiatry and so forth. But can somebody, maybe Heather or Steve, give us a quick update on where that stands, and is that really impaired now in this circumstance, or are we moving forward?
What's that?
For the hospital-based peer recovery programs. What's the status
Oh,
of?
that's great. Suzanne could probably speak to it, and maybe you could also, Margaret, if you could activate Peter Treitler's mic. He's been looking at this very closely as well. But maybe Suzanne could get us started with that.
Yeah, I'd be glad to. The opioid overdose recovery programs, we call them the ORPs, are a program that my office oversees. And we currently have them in all 21 counties, and they're in 57 of our 75 acute care hospitals. So we have, huge coverage. And one of my goals is eventually make sure every hospital has one. So for those providers that are actually part of the hospital system, it's really had no impact because the hospital employees, the peer recovery specialists are treated as hospital employees. They're on the payroll. So like one of my providers, the Barnabas system, I think they have 7 of our ARP programs. It's really had no impact. As I said, the staff are treated just like any other medical staff, and they're given the necessary PPE and all the precautions, and they continue on. Definitely more challenging for the other programs that are not part of the hospital system, that they're an outside vendor, like a prevention program, because hospitals are restricting access. So they've had to adapt, again, using telehealth and virtual types of, approaches. And then, we'll deal with the client once that client gets discharged, from the hospital and, our current, COVID world. But as I said, it's moving on, our program, continues on, and I expect it will continue on for the foreseeable future, because this is a way, we think we need to be moving. We need to start investing more of our money into recovery support and to prevention, as, Medicaid came along and is really picking up our treatment costs. So this will be, as I see it, as an ongoing program, because we have evaluations going on, and we know what an impact it's had on the lives of these clients that are being served by our teams in the hospital.
This distinction that Suzanne has just made, I think, is incredibly important, and it kind of reminds me of all the struggles that Aaron went through in Newark to try to create the true warm handoff and the true continuity. So the hospital-based programs and the hospital-based initiation of buprenorphine, the long-term effectiveness of it likely varies depending on whether that truly engages a person in continuing care or not. So the fact that you have these organizational differences, is it being done within one organization, or is it fragmented organizations where people have to make these transitions that they don't necessarily make well? I think these are some of the things that I think we will learn from the analysis with Arnold that we hope to be doing with Nina Cooperman and Anna Klein and Joel and I and Peter. But that it's really a provocative thought that these organizational differences actually make a difference to effectiveness. So this is sort of what I was talking about with envisioning what the next stage is. And I think the next stage does involve serious conversation with Medicaid, and it involves the gradual move towards more integrated models that really fund the package, so that you have the first aid, if you like, which is the emergency intervention at the ED level, and then you have how does that so for example, the organizations where the MAT is provided within the same organization as the hospital system might possibly do better. Those are hypotheses that we could look at. Aaron has watched this evolve in Newark. Do you have any comment on how that's evolved Aaron?
Of course I do. Yes. And I was actually going to jump in just to say, because I think it's another important policy point that I just want to make sure to drive home to everyone. The biggest problem that we have with transitions of care for these patients with opioid use disorder is this waiver issue for doctors and providers for buprenorphine. And so I don't know how many people know, but you have to get what's called an X waiver. And you could be a physician assistant, a nurse practitioner, a midwife, a nurse anesthetist. There's like a variety of providers that can get this waiver, but it's basically an additional 8 hours of training, in order to prescribe buprenorphine for opioid use disorder. Ironically enough, you can actually prescribe buprenorphine for pain without this waiver, but it's a special waiver. And this was created in 2002. And this is like kind of the new way to do like methadone. We've done these really draconian, very over-regulated methadone clinics since the 1970s. And so, and it was supposed to be a pilot and become looser, and around the world, there's many places where they do methadone with much less regulation, and you can just go to a regular pharmacy and pick up your methadone in Europe and places, but we don't do that here in the US. We have this very kind of restrictive OTP, opioid treatment program regulations. Buprenorphine is the office-based option, which was introduced in 2002, which was really a huge advance. But the problem is this waiver requirement with the extra training, it puts you on a list with the DEA, and it means that the DEA can do an in-person site visit to make sure that you're only treating a concurrent panel of patients of 30 in the first year, 100 in the second year, et cetera. There's like all these rules and regulations, and we don't regulate any other medication in all of healthcare in this way. And the greatest irony of all, of course, is that buprenorphine is a partial agonist, so it only activates the opioid receptor at 40%. So if you're completely naive to opioids and you take an overdose of buprenorphine, which would have to be under your tongue, so you're like putting multiple film strips under your tongue, you won't have respiratory to the depression to the point of overdosing and dying. It's the safest opioid that we have. And then we're now making it the hardest opioid to prescribe. So on day one of being an attending, when you graduate from medical school and residency, you can prescribe fentanyl, oxycodone, Dilaudid, you can start people on drips, you can do whatever you want, but you cannot write them a prescription for buprenorphine on their way out the door from the hospital. And only 5% of doctors across the US have this waiver. So it becomes this panicked, rushed, urgent thing when someone's in the ED on a Friday night, and amazing peer navigators are there, peer recovery specialists ready to start treatment for them, and there's no waiver provider in sight. And so how are you going to bridge them to Monday or Tuesday? And they could literally overdose and die over the weekend. And so I think we've really, there's a big advocacy movement now nationally to get rid of this waiver. And I just want to put a plug that there's a current bill, it's called the Mainstreaming Addiction Treatment Act, the MAT Act. And it's actually sitting in a committee that is chaired by Congressman Frank Pallone, who is here in the 6th Congressional District in New Jersey, which is Middlesex and Monmouth counties. So just want to do a shout out to his constituents that he has sole discretion to move this bill out of the committee. And I know Heather is loving this when I'm saying this, but he has discretion to move it out and kind of move it forward. And we're really close to potentially federally being able to get rid of the waiver, because there's a lot of support for this, both at local and federal levels. So just pointing out that transitions of care are incredibly hard when you have burdensome things like waiver restrictions.
Yeah, I have to agree wholeheartedly with Erin. And one of the things I've been trying to do since the inception of ORP is to get the buprenorphine started in the ED. And one of my providers was finally successful in doing that. It took her a good year to make it happen, but that's in the Barnabas system. So they are able to finally do that. They have the waiver doctors, and they, provide, I think, a 3-day script. So when the person leaves, they have a 3-day prescription, to then hook up to care, which our recovery, specialists will help hook them up with. And I believe one of my other hospitals, might be doing this too. I don't know if Atlanticare is doing it, and in Spira, there might be another one, but it's really important, that we get this to happen. And one of the things, I have another program called the ORO program, the Opioid Reduction Options Program, where we're trying to reduce the prescription of opioids in the EDs. And one of the things we're going to add to the training is this fact of, trying to encourage those hospitals that are participating in that program to get involved with the transition of care and prescribing buprenorphine in the ED, and then, hand the client off to, a provider in the community.
I just want to add that there is zippo reason for this waiver thing to exist, except for stigma and discrimination. And it filters down through the doctors in the hospital system. I worked in a couple of the ORP programs, and trying to, as a non-medical professional, trying to educate a medical professional on a medication it's not a winning battle that I was ever really going to have. So trying to convince doctors why they should apply for this waiver, it's ridiculous. Like, they don't need it. And it's putting up, again, it's huge barriers and misinformation and misunderstanding that starts at the federal level and just kind of trickles down to everywhere else. In this epidemic that we're looking at, it's a huge barrier that needs to go away.
Sort of consistent with the American allergy to harm reduction generally. You know, the evidence supports what you're saying, but evidence doesn't always matter, unfortunately. Well, while we're on that subject, and a question that's come in a couple of different ways relates to the ability to advocate to make some of the changes that we've seen in the pandemic permanent, telemedicine being most notable. The question is there research going on to generate the data necessary to advocate to sustain these changes?
And there absolutely is. And there's an increasing amount. I think there's more that we all can do to bring everybody together who's doing that research. But the DMOS has provided some of it. I think we're going to see results from some of the various evaluations. The work that For Foundation has been generous to provide, I think, is providing some of these answers. But then how you make the next step towards rapidly moving from translational work to move those research results into the policy discussion. It was the piece of information that Aaron gave us about the legislation, coupled with the legislation that's been moving forward on harm reduction in the Senate. We have some progressive legislators who are very interested in hearing what the result is. We have some other people on the Assembly side that will require, I think, more discussion. But I think, and I really appreciate what Heather said. We found, interestingly, that in the stakeholder advisory group for our FOR program, it sort of started turning into a forum for these different stakeholders to speak with, and with the research community that we didn't have before. So we need to figure out how to move that forward. But I truly appreciate what Aaron said, that we have right within our state some federal legislators who, and I'm not sure what the optimal way is to engage in that discussion, but I know there's a way, and I know that this group that has sort of come together will be able to figure out the best way to really weigh in, both on the more experiential level and on the more formal evidence level, because both exist, and as I said, they're really becoming somewhat convergent.
One of the things that I do at NCAT as the advocacy coordinator is I run grassroots advocacy teams across the state, because we believe that when it comes to stuff like this, we have learned from experience, if our legislators do not hear from their own constituents, we are not getting anything pushed through. So one of the other benefits that has come out of this completely digitalized age that we're in now is that we actually have a network that we use where we can set up actions where people can just fill in their information and send things off to their elected officials, whether it's their federal officials or their state officials. So we have a pretty wide network, but this is something that, I would love to be able to send out to everybody that they could send out to their networks, because the only thing that gets these pushed through is a lot of people, is numbers.
That's right. And I think that some of the research results that are very robust are, number one, MAT, including buprenorphine, is highly effective as a risk reduction. It is not a magic pill that lasts forever once it's discontinued, and that the optimal duration of treatment is much longer than we see in actual practice. So that means that we need to keep maintaining these things to be as low barrier as possible, and really focusing on retention. I mean, roughly speaking, you see a reduction of overdose risk down to a third or a quarter while people are on treatment. But after the cessation of treatment, the risk almost goes up to baseline unless someone has been in treatment for long periods, 18 months or longer. So that's a piece of information. Another piece of information that we have from research that I think is very important is that buprenorphine diversion is not a problem. And in fact, as what we're starting to learn from Robin Williams' work, amazing work with data on 18,000 people from the Clean Slate Network, is that just speaking very qualitatively at this point, is that and from many other studies as well, besides Robin, that when buprenorphine is used on the street, it's typically used sort of for self-MAT, if you like, or almost informal treatment, and probably reduces people's risk. And there's a widespread sort of informal system that we're only beginning to understand of self-treatment. So this is critically important, because we don't need to make providers jump through circles to try to minimize buprenorphine diversion. So those are just a couple of the findings that we have from research that I think are critically important for these policies, and we need to get them to the decision makers.
Great, thanks. So the clock is ticking here, so I wanted to get to a couple of more questions. A couple of folks have asked, have things changed in terms of access for people without any insurance coverage? And related questions about certain plans not covering certain drugs or making it more difficult to prescribe. These are sort of questions that go to the provider. So I don't know, not to put you on the spot, Bob, but do you want to chime in first here?
Sure, Joel. I think that access has improved for individuals that do not have resources. So these are individuals that either have Medicaid or they're not Medicaid eligible, which happens in very rare cases. We ended up with a great system here in the state of New Jersey, where many organizations throughout the state were able to actually get the presumptive eligibility taken care of when someone presents themselves for treatment. So there's definitely better access today than there was before the Medicaid expansion in New Jersey and before the Affordable Care Act. The other thing that I wanted to say and respond to one of the questions is any rapid improvements. A rapid improvement that we're seeing is that, and this is tied to integration of care, is that we are seeing that we know a whole lot more medically about the people that we're working with now. So these are individuals that are coming to us for addiction disorders, mental health disorders, but because of the COVID pandemic, we are monitoring their health, much closer than ever. We have, the pulse ox, monitors, the temperature checks, the symptom checks. So we are, by way of the pandemic, we're certainly integrating more today than we were before the pandemic. The other thing is that forums such as these are just amazing. That I've been a part of a couple of these forums, and the ability to get people together through this virtual media here, we're able to come together and just share our experiences. And then when we leave this forum, whether it be the participants or the panelists, we are going to follow up and we're going to make some changes. I know another thing that was in the chat box was about the city of Newark and the amazing integration, collaboration that happened here. I know that Aaron and I are part of a weekly standing meeting along with Dr. Denise Rogers, Dr. Mark Wade, the Mental Health Association of Morris and Essex, the Newark Housing Authority, other providers. We all come together once a week to talk about the homeless population in the city of Newark and how could we make sure that we're meeting the needs of those individuals. So I'm sure it's happening in other parts of the state also, but I think what's happened in Newark is really a model. And that's been another one of the blessings or the silver linings from the pandemic.
Thank you. So
I'd also like to add to,
yes.
From New Jersey's point of view, is that we're very fortunate. We have numerous funding streams, and people, for the most part, should be able to get connected through one way or another. Of course, probably one of the biggest funders is Medicaid. So, and as Bob was mentioning, our providers have gone for training on doing the presumptive eligibility, and so that's a key funding source. Then we have numerous state resources. We have our various state fee-for-service programs, and they're basically, the eligibility is up to 350% of the poverty level. So for anyone who doesn't have Medicaid, there's state resources available. We get funding from our substance abuse block grant, because addiction treatment isn't really well funded by state legislature. We do get a significant amount of funding from the federal government, from SAMHSA, for both treatment and prevention resources. So that's another big funder. We have specialized money under Chapter 51 called the AEREF, which stands for the Alcohol Education, Rehabilitation, and Enforcement Fund. And that's based on need, and we allocate it to every county, to our 21 counties. So our county alcohol drug and directors, they are available to provide assistance to clients who can't seem to find, a funding source, and they will help, the clients of their county get into treatment. And then not to mention all the federal money lately that's been pouring into our division, with the, latest one being our SOAR award for the $66 million. So there is a lot of resources out there. And there's the Reach NJ for people to call that can help navigate them through this, or their, county director.
Thank you. So we are running up against the end here. So I think I'm going to change the format just a little bit. We're going to do a lightning round of comments. So everybody, my question is, thinking about the year to come, which of course there's enormous uncertainty, but we're pretty sure that we're not going to have the vaccine in the next 2 weeks, and by the end of the year, it'll be well distributed. We're pretty sure about that. But in the coming year, what do you see as the biggest barriers to access to treatment and care? And if you can't help yourself, you can say 2 things, but I'll start with Heather. Let's start the lightning round.
So I foresee a lot of demand for both substance use disorder, and that's substances across the board, not opioid specific, especially alcohol, and co-occurring mental health treatment. And there are not enough facilities that are licensed and practiced in both in New Jersey. We had a capacity issue before COVID. I anticipate that we may really run into some issues going forward. So I'm hoping that some more resources will be available, and some places that have applied for licensure, that maybe that'll happen. I'm very worried about capacity. I think that demand will outstrip capacity in the next few months. That's a big worry of mine. So I do hope that a lot of people are looking at more in community support and in community treatment options for people that may not be able to go inpatient or outpatient.
Mm-hmm, mm-hmm. Thank you. Continuing the lightning round, Erin, the coming year.
Yeah, I mean, I guess I'm going to change it a little bit and just say kind of a larger stepping back, talking about insurance in general. I think we just all need to point out we need universal health care. We're the only developed nation in the world that doesn't have it out of like 33 countries. It's just insanity at this point. And then also this irony that the pharmaceutical companies are still basically getting away with murder and charging enormous amounts for buprenorphine. It's incredibly expensive. And the irony, of course, is that we use state and federal grant money to then pay for medication. So we're literally using taxpayer dollars to pay pharma. And then there was a huge settlement that just happened with the brand name Suboxone, some really, kind of illegal marketing practices that they've done, and people now, patients can sign up to be part of that settlement. So just realizing that we're in this like for-profit corporate healthcare state in this country, and that needs to change, that we just need to have everybody has healthcare coverage, and the cost of drugs needs to go way down. And so I think, I know that's too big and we can't do anything in the next year, but
very good. Yeah. The solution is just getting there, right? Bob, something to add on the way out?
Yes. What we could expect over the next year and the barriers. So we're going to have long-lasting impact on our mental health as a result of this pandemic. And you could go back, you could look at events like 9/11, Hurricane Katrina down in New Orleans, Superstorm Sandy here in New Jersey. We know, we do not have the data yet, but we know there's going to be an increased demand for services. The biggest barriers right now are the Data 2000 waiver, which Stephen and Erin spoke about, that it's it's almost unbelievable that a doctor could prescribe anyone unlimited OxyContin or hydrocodone. But if a doctor wants to prescribe a potential life-saving medication to help someone addicted to opiates, they have to jump through hoops. The other thing is that the barrier to integrated care is that getting all of the licenses that are required for addiction treatment, mental health treatment, and also a primary care license, it's very burdensome. And it's very difficult. You have a lot of well-intentioned providers that have the resources and want to help people, and getting the licenses that you need remain a challenge.
Thank you. So we are right up against the end of our time. So I'm going to apologize to Steve and Suzanne that we'll give you a first up on the next panel, and just ask Margaret to sort of give us a closer, and we'll go from there. Margaret, go ahead.
Great. Thank you all very much. This was a terrific discussion. It was great to hear from all of you. To our panelists and to our participants who we tried to answer as many questions as we could. Just a reminder to please complete, we'll be sending out the link after this session to complete the feedback survey. Somebody asked if we could share the panelists' contact information. We'll check with them, but I suspect it would be appropriate. Erin already okay, so we'll follow up. Erin just put hers in the chat, and we'll also keep you on the invitation list for our future policy forums. So a warm thank you to everybody today. Take care and stay well, and we'll see you again soon. Bye-bye. I think we're good. Bye-bye. Thank you.
Thank you. It was so much fun. Thank you.
Good. Thanks, everybody. Have a good weekend. We'll
Thanks,
be in
guys.
touch.
You too.
Bye-bye. It was terrific.
Thanks so much to Joe and Margaret.
Yeah, thanks
Bye-bye.
for putting this together.
Thanks, everybody. Takes a village. Bye-bye.
Okay, bye.
Hi, Steve.
Hi.